So the normal MCV in pediatrics depends on the age. For 6 months to 1 year, it will be 70 to 85. So the child in the question is 6 months and this is 86. MCV is 86. That means we have to check our options back. Check back the options given. 6 months old plus splenomegaly plus pallor HB 9 retix 10 MCV 8 and other labs normal. Here he has given the answers hereditary spirocytosis, but the other options for this question is
The thalassemia diagnosed by CBC by MCH, yes, and feature like iron deficiency, not MCV, no, are we
the
right?
other. No, here MCV, here the cells are spirocytes, but in thalassemia trait it will be microcytic. They are microcytic hypochromic.
Yeah.
In sickle cell anemia, also you see the sickle, sickle shaped cells. And I think they are also microcytic. We don't see this MCV 86 in other than hereditary spirocytosis here. That's why that is the option. This study highlights a significant reduction in hemoglobin values in HBSS subjects and notable of elevation in MCV values in HBSS blood group. Elevated MCV in sickle cell anemia, where red cells are typically microcytic, warrants further investigation of differential diagnosis. So usually the MCV in sickle cell anemia is typically microcytic. It is typically microcytic in both in thalassemia and sickle cell anemia.
Yeah.
But if you see an MCV elevated, then it warrants further investigation for differential diagnosis. So that means MCV is low in both. So the only option here which we have to choose will be hereditary spirocytosis.
Yes.
Newborn with hemorrhagic disease, which is true. Factor 5 abnormal, factor 7 normal, PTT normal, and bleeding time normal. So a hemorrhagic disease, usually bleeding time will be normal, right? Here he is telling vitamin K dependent factors are 2, 7, 9, and 10. Okay. In hemorrhagic disease, prothrombin time, coagulation time, and partial thromboplastin time are prolonged. All are prolonged. Prothrombin time, coagulation time, and activated partial thromboplastin time are prolonged. Levels of prothrombin, see, vitamin K dependent factor is 7. Factors 7 and 10 are decreased. So bleeding time, platelets, capillary fragility, factor 5 and 8 are normal. So we have to remember all these things. So bleeding time is normal, but here APTT will be abnormal. Factor 7 will also be abnormal. Factor 5 will be normal. So in all these options, see, the options are so confusing. So how to remember this? Easiest way is we have to always remember the vitamin K dependent factors. We have to memorize this. The vitamin K dependent factors are 2, 7, 9, and 10. 2, 7, 9, and 10. So obviously there will be 7 will be abnormal. Prothrombin will be abnormal. 9 and 10 also will be abnormal in case if it is given. But what is normal? Bleeding time will be normal. Capillary fragility will be normal. Factor 5 and 8 will be normal. Any factor other than 2, 7, 9, 10 will be normal. Okay. So prothrombin, factor 2, factor 7, and factor 10 are decreased. Yes. So you see prothrombin time, coagulation time, and partial thromboplastin time is prolonged. So to remember all this, you should remember these numbers, then you can remember everything. Again, newborn with hemorrhagic disease, which is true. Bleeding time is normal. But here he has not given us the explanation. So vitamin K dependent factor, he has written 7. So let me prolong it. In hemorrhagic disease, prothrombin time, coagulation time, partial thromboplastin time, or prolonged prothrombin and factor 7 and 10 are decreased. Bleeding time, platelets, capillary fragility 5 and 8 are normal. So as I told you, the clue is to remember the factors. Next, vitamin K dependent factors. We know that 2, 7, 9 and 10. Child with hemophilia B plus joint hemarthrosis, weight 20 kg. To increase his factor to 15%, how many units you will give him? So we have to remember this formula. This is very important. Weight in kg into percent of factor to be increased. So here in the question, it's given for us child with hemophilia B, joint hemarthrosis, weight is 20 kg, increase his factor to 50%. Percent of factor we have to increase is up to 50%. So the formula for hemophilia B is weight into percent of factor to be increased. Now the weight here is 20 kg. 20 into the percent of factor to be increased is 50. So 2 5s are 10, then 2 zeros. So 1000. 1000 is the answer. So we have to remember this formula. Weight into percent of factor to be increased into 50. Into 0.5 for hemophilia A. But for hemophilia B is weight into percent of factor to be increased. No need to multiply by 0.5. I need to run this. Let us check, confirm in the Google this one. See, the vitamin K coagulation factor dependent factors are 2, 7, 9, 10. And also we have to add protein C and S to it. Okay. 2, 7, 9, and 10 and protein C and S. Patient with lymphocytic leukemia, there is scenario of hematuria, reduced urine output, reduced hemoglobin, and increased urea and creatinine 375. Total leukocyte count is 20,000. So here there is urea too much increased and creatinine is 375. Picture of renal failure, and also there is hematuria, reduced urine output, and total leukocyte count 22,000. So what do you do? Forced dialysis. The data indicate that young platelets are more active than older platelets. This study demonstrates that size and age are both determinants of platelet function, but by independent mechanisms. So young platelets are more active than the older platelets. And also,
The explanation, not relation to the question.
no, this is some other. This is for the other question. There was question here before. You see this question. There was one question on platelets. Now he is giving the answer for that question. Okay. Young platelets are more active than older platelets. If I get the question, I will post. Okay. Somewhere here. This more younger, more active. For this question is giving the answer there. I don't know. This book is something mixed. Okay, next question. This the same thing is given in the other book also, this one. Now, a case scenario of sickle cell disease plus lab plus splenomegaly. Usually, sickle cell disease with splenomegaly means it will be sequestration crisis. Because in sickle cell, as the child grows, I think by 5 or 6 years of age, there should be autosplenectomy. In children, usually there will be sequestration crisis. This one, case scenario of sickle cell disease plus last baby has aplastic crisis. We don't think I see the splenomegaly in aplastic crisis. In hemolytic crisis also, it is sequestration crisis. Baby, usually children, small children with sickle cell disease will have sequestration crisis during the small ages, younger ages. Next is, again, this is not related. I will just read it. Evans syndrome is the presence of simultaneous sequential direct Coombs positive autoimmune hemolytic anemia in conjunction with immune-mediated thrombocytopenia with no known underlying etiology. Evans syndrome means you have autoimmune hemolytic anemia with immune-mediated thrombocytopenia, both. Autoimmune hemolytic anemia with immune-mediated thrombocytopenia. Because of that, you will also have what? Coombs test positive. Evans syndrome is an autoimmune disease, which means that your immune system malfunctions. It mistakes part of your body, in this case, certain blood cells, for a foreign invader and launches an attack. Special immune cells called B cells create antibodies that recognize and seek destroy certain type of blood cells. Evans syndrome is an autoimmune condition that presents with 2 or more cytopenias, which commonly includes autoimmune hemolytic anemia and immune thrombocytopenia with or without neutropenia, only 15% of cases. So the common thing is autoimmune hemolytic anemia and immune thrombocytopenia.
I mean low platelet and low hemoglobins.
Yes.
With normal neutrophils.
Yeah, there is only in 15% of cases you can also see neutropenia.
Okay.
Yeah.
And no relation with the platelet, just hemoglobins. Yes, hemoglobin and platelet, not related to white blood cell.
Immune mediated, that means your bodies will think normal cells as foreign cells and it is killing. That is what the explanation is given. Immune mediated destruction of red blood cells and platelets.
Yes.
Chest X-ray of child diagnosed with Hodgkin's lymphoma shows solitary lymph node. So solitary lymph node means stage 1. Okay. In Hodgkin's lymphoma, there are stages. So stage 1 is only one group of lymph nodes are involved. Stage 2 means if this is the diaphragm, 2 or more groups involved on one side of the diaphragm, in either one side, either the upper or lower to the diaphragm. Stage 3 means 2 or more groups involved in both the sides of the diaphragm. Stage 4 means along with this thing, if an organ is involved, suppose if it has invaded the liver or something, this is stage 4. So here only solitary lymph node means it will go with stage 1. Child with HUS, hemolytic uremic syndrome, investigation WBC8, ESR 68, urea 7. Which of the following support your diagnosis? Increased platelets, normal creatinine, positive reduced heptoglobin. HUS means hemolytic uremic syndrome. Here I think there is hemolysis, right? Hemolytic, it is. Hemolysis is there. Whenever there is hemolysis, what happens? There is reduced heptoglobin level. Why? Because heptoglobin will bind to HB, hemoglobin. Hence, reduced HB lead to reduced heptoglobin. What happens is, what I understand is, whenever there is hemolysis, that means the red blood cell is broken and the HB will come out, hemoglobin. And this hemoglobin will bind to heptoglobin. Heptoglobin bind to hemoglobin. So if we take heptoglobin as HPT, it binds to heptoglobin. So hence reduced HB will lead to heptoglobin. Let's see if there's any other explanation in other unit. Same thing he has given. Case scenario of sickle. This is sequestration crisis. A chest X-ray of child diagnosed with Hodgkin's lymphoma shows solitary lymph node. Again, it is stage 1. Child with hemolytic uremic syndrome, investigations WBC8, ESR 68, urea 7. Which of the following support your diagnosis? Again, decreased heptoglobin. He also has given heptoglobin bind to HP, hence reduced HB will lead to a reduced heptoglobin. Same, I told you the stages here, if you can see. Stage 1, one lymph node or extranodal tissue. Stage 2, one lymph node or extranodal tissue on same side of diaphragm. Stage 3, more than one, this. More than one lymph node or extranodal tissue on both sides of the diaphragm. Stage 4 is diffuse or disseminated. This is for the Hodgkin's lymphoma. What is true about hemophilia? He's telling diagnosis in a newborn. What is true about sickle cell disease? Again, diagnosis in a newborn. But we have to check what options was given there. So let's check here. Here, what is true about hemophilia? Factor 9 is reduced, is the most common. No, factor 8 is the commonest, right? I think factor 8 hemophilia.
I see hemophilia A and hemophilia B. Hemophilia
Yeah,
A 9 and hemophilia B.
No, hemophilia A is 8. Hemophilia B is 9.
Yeah.
We can check again. Usually presented with mucous membrane bleeding. No, it usually presents with arthrosis, not the mucous membranes bleeding. Mode of inheritance is same as von Willebrand. No, it is wrong. Diagnosis in a newborn is correct. I think all these three is not correct for hemophilia. Hemophilia
Yeah, I think
8.
von Willebrand maybe autosomal dominant recessive, but hemophilia is X-linked.
Yeah, X-linked. Von Willebrand is not X-linked.
Yeah.
So let's check about hemophilia. Hemophilia. A. Classical hemophilia is also known as hemophilia A, is a hereditary hemorrhagic disorder from a congenital deficit of factor 8 and manifests as protracted or excessive bleeding either spontaneously or secondary to trauma. Common bleeding. Common bleeding. Severe hemophilia is where factor 8 and 9 levels are less than 1%. Bleeding can occur even with minimal activities of daily life. Bleeding may also occur with no known injury. Bleeding most often occurs in joints, muscles, and in the head, not the mucosal. Mucosal is not the commonest in hemophilia. So whatever here options he has given is not correct. Masalan, factor, because hemophilia, commonest hemophilia is factor 8 deficiency. Hemophilia B is factor 9, but it is not the commonest. And it usually presents with joint and muscle and brain,
Head.
thing in the brain. Mode of inheritance, no, it is X-linked recessive. Diagnosis in newborn, yes, I think it is more common. What is true about sickle cell disease diagnosed by sickling test? No, sickle cell disease, even if you do sickling test, but the diagnostic test is HB electrophoresis, right?
Yes.
Early diagnosis does not improve prognosis. No, definitely early diagnosis will improve the prognosis. This is also wrong. So diagnosis at newborn. We are doing newborn screening for sickle cell disease, no? Newborn screening is being done.
Yes. Yes.
Yeah, let's check what is the inheritance for von Willebrand disease. I think it is autosomal dominant. Von Willebrand disease. Inheritance. Von Willebrand disease has different inheritance pattern. Most cases type 1 and type 2 are inherited in autosomal dominant pattern. So it is an autosomal dominant inheritance. Next is child came with fatigue, picture of anemia and stunted growth, and his blood work shows microcytic hypochromic anemia. So microcytic hypochromic anemia usually you can see this in thalassemia also, sideroblastic also, lead poisoning, iron deficiency, and sickle cell anemia. All are microcytic hypochromic anemia. But what is the thing which is pointing you here to iron deficiency anemia? This is very important. Picture of anemia and stunted growth. Stunted growth you can see in all.
Yeah.
Work shows microcytic.
I think chronicity, prolonged time.
Yeah, but still, all these examples are microcytic hypochromic anemia, thalassemia, sideroblastic.
Not come with jaundice, maybe. If come with jaundice may indicate thalassemia, sickle cell anemia, retic count high. No mention anything.
Yeah.
Just microcytic hypochromic.
Yeah, so I think this question is incomplete. Serum, but we have to remember this serum ferritin is the first sensitive test to diagnose iron deficiency anemia. So serum ferritin is the first sensitive test to diagnose iron deficiency anemia. Thrombocytopenia plus small platelets we see in Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome, one is wrong. We see thrombocytopenia and also small platelets. We see eczema, we see recurrent infections. More common in males? No. The triad of Wiskott-Aldrich syndrome is thrombocytopenia, eczema, and recurrent infection.
I think it's X-linked because that is not common in the female.
Here also same question. There is no difference. See, here it is given. Wiskott-Aldrich syndrome, thrombocytopenia, eczema, and recurrent infection is the triad. So more common in females is wrong. But we should know what is the inheritance of Wiskott-Aldrich syndrome. We can put it here. X-linked inheritance pattern. So it should be more common in males, not in females. Child with bruises. His father also has bruises, giant platelets, and thrombocytopenia. Heglin anomaly, and it is AD he's writing. Next, one more question. Child with bruises, giant platelets plus thrombocytopenia. Barnold-Salver syndrome. Coagulopathy plus low glycoprotein plus low receptors of 1 millibrand factors 8. So we should know the difference between these two syndromes, Heglin anomaly and Barnold-Salver syndrome. So in the first, he is telling child with bruises, yes, there is giant platelets, there is thrombocytopenia in both. But only thing here he is telling father is also involved because there is autosomal dominant inheritance. Here, the father involvement will not be mentioned because this is autosomal recessive inheritance. That is how you have to differentiate between these two questions. If they say that the father has the bruises, same question with only extra point is father has bruises, you will choose Heglin anomaly. If nothing discussed about the father, you will choose Barnold-Salver syndrome. Same thing he has given here. Child with bruises, his father has bruises, giant platelets, and thrombocytopenia, Heglin anomaly. Child with bruises, giant platelets, thrombocytopenia, Barnold-Salver syndrome. The only difference is this is autosomal dominant and this is autosomal recessive. And also you see low glycoprotein, coagulopathy, low receptors for 1 millibrand factor 8. See. See, the question is rate of transmission of hemophilia from affected father to his female offspring. So let's now take an example like the father is affected. Affected father means X has dot here. Y, no. Mother is normal. So all the female fetuses will receive the X from the father. So all the female fetuses will be 100% carrier here. They will be 100% carrier. I think it's clear, right?
Can repeat the last explanation, please?
Which hemophilia one? Which one? Hemophilia one?
Yeah, hemophilia.
Yeah. See, in hemophilia, now we will take an example. He is asking that hemophilia from affected father to his female offspring. So affected father is XY, right? He is affected. So we will keep the dot here. Mother is not affected. We'll just write XX. Okay. Now, when any female which comes out of this is, all females which comes out of this is they are carriers because the father is, they will definitely from the father. So all the females which come out of this relationship will be 100% carrier of hemophilia, he's telling. Because all
Yes.
X's they receive from the father.
Yeah.
This is the explanation. Next is treatment of autoimmune thrombocytopenic purpura in baby has platelet count 30,000. Autoimmune thrombocytopenic purpura in baby with platelet count 30,000 has purpura and ecchymosis. So, but it is only platelets. Why not the IVIG? Let's see what the explanation he has given. After delivery, if severe thrombocytopenia persists, transfusion of 1 unit of platelets that share the maternal alloantigens, example, washed maternal platelets, will cause a rise in platelet counts to provide effective hemostasis. This is from Nelson, he is telling. So, all alloimmune thrombocytopenic purpura in a baby whose platelet count is 30,000, you will give washed platelets from from the mother. He's telling after delivery, if severe thrombocytopenia persists, transfusion of 1 unit of platelets that share maternal alloantigens, example, washed maternal platelets, will cause rise in platelet counts to provide effective hemostasis. You have to wash, I think, you have to wash the platelets to receive this maternal alloantigens, because this is autoimmune thrombocytopenic purpura. See, this is the question. Same question. Treatment of autoimmune thrombocytopenic purpura in a baby has platelet count 30,000, has purpura and ecchymosis. IVIG is there is an option and vast platelets. Now, calculation of dose of factor 8 and 9. Factor 8, how do you calculate factor 8? Target factor 8 minus baseline factor 8 level into body weight into 0.5. For factor 9, target factor 9 minus baseline factor 9 level into body weight into 1 unit per kg. Or factor 8, mild or moderate, 30 minus severe life threatening, 100 minus 150. This third line I did not understand. But these two I understood. Factor 8, suppose in the body there is only 10% factor. Baseline factor in the body is just 10%. You want to raise the level in the body to 50%. So what do? You want to raise to 50%. In the body, there is already 10%. So 50 minus 10 is 40. So you will multiply 40 into body weight. For example, 20 kg into 0.5. Whereas for hemophilia B, this 0.5 is not needed.
Can 0.5 I multiply in the body weight, I think. But why 0.4?
Where is 0.4?
I write something in screenshot like the body weight like 20 multiply in 0.5 and multiply by something what?
No, for example, your body already has 10% of factor. You need to raise the body factor to 100, you keep. You want 100
Yeah.
factor 8, but your body already has 10%. So 100, your target is 100. But already there is 10% in your body. So you'll subtract whatever your body has, right? So 100
Yeah.
minus 90. This is what he's telling.
Okay, thanks.
But it depends on the question. In the question, if he gives like this, baseline factor, if he gives already, then you will do it. If he doesn't give, you will do the previous one which we saw before.
Yeah, 10 it is the baseline factor level.
Yeah. Treatment of alloimmune thrombocytopenic purpura in baby has platelets. We already read this. But let's see what the Google says about. Treatment usually involves platelet or antibody transfusion. So, treatment usually involves platelet or antibody transfusion. Neonatal alloimmune thrombocytopenia is a rare but potentially severe condition that affects newborns. Doctors also call it fetal or neonatal alloimmune thrombocytopenia, and as it can also affect fetuses. So, how do you treat it? Platelet or antibody transfusion. Fetal alloimmune thrombocytopenia is treated by platelet transfusion is the treatment of choice. Transfusion is indicated in term neonates with